Okay. Morning. So that ends our calcium and metabolic bone disease section of the course, save one anecdote. You may ask yourself when you're on the floors, how is it that I'm going to remember that hyperventilation and respiratory alkalosis induces a conformational change in albumin that promotes binding of free calcium and induces hypocalcemia? So when my wife was giving birth to our first child, she begrudgingly accepted me as her coach. And when we were in the triage suite and we were doing all these breathing exercises, she hyperventilated. And when the nurse went to check her blood pressure, her hand did this, which you will learn about later today, is known as the Trousseau sign. And I was standing a few feet away when I saw that. And I said, whoa. So I walked up to her and I tapped her on the face. And her face twitched. And I said, wow, a real swastika sign. You don't see this every day. When our second child was born, I was in the waiting room. So today we're going to talk about endocrine hypertension. And I put up some goals of the talk. I'm going to briefly review the renin-angiotensin-aldosterone system. And this lecture kind of covers the adrenal section in your syllabus, and also there's an endocrine hypertension section in your syllabus. There's parts of the syllabus for endocrine hypertension that I will not be discussing here. And your syllabus goes very much in depth to the basic science physiology of how renin-angiotensin and aldosterone work. And it's really quite important to know that. So I'm going to review that a little bit here. I know you've had it in renal because I looked over your slide set from Dr. Raff's course. But we're going to spend a large amount of this talk on a disease called primary aldosteronism, of which there are a few causes. And I'm going to put up a little case scenario, and we're going to use that case scenario to go over the presentation clinical features of the lab evaluation for the imaging and other related tests that we use in and the management strategies for this disease. Primary aldosteronism has a few different causes. There's two causes that make up the vast majority of them, and they are treated markedly differently. And so it's really important when you're working somebody up for this disease that you keep that in the back of your mind. There are also some other sort of fascinating mechanisms of endocrine-mediated hypertension that we'll touch on today. And then I'm going to give you a recipe for whole wheat pumpkin muffins. Why am I going to give you that recipe? I'll tell you why. Because it was 15 years ago, this month, that actually started my medical school training. And I did medical school out in the Midwest. And I went pumpkin picking and was treated actually to a pot-bellied pig race, which is not something from Long Island I'd ever seen before. But I picked up a card for whole wheat pumpkin muffins, and they're really good. And this time of the year, it always reminds me, and I always start making it, so I thought, I'll share it with you. You could decide if you're going to make it on your own. All right. What we will not cover today, but you will remain responsible for. Cushing's syndrome, we'll talk a bit about it today. FEO is coming tomorrow. Acromegaly and thyroid-related disease you've already had, and renovascular hypertension I'm going to assume that you already know about. So let's talk about hypertension just generally speaking. The overwhelming majority of hypertension is very poorly understood. We don't know why most people have hypertension. It's called essential. You could also refer to it as idiopathic. We just don't know the etiology or manifestations for why it is there. However, that 15%, it may be less than that, we're not really sure, but that 15% of patients who have an endocrine-mediated cause of hypertension, also known as secondary. There's various types of secondary hypertension. But when there's an endocrine cause, we have strategies for specifically treating those forms, and they're very effective. And so it's really important to be able to say in your mind whether or not somebody may have an endocrine-mediated form of hypertension, and then sort of work through that evaluation to decide if they do, because if they do, they have a form of hypertension that's actually quite treatable if you can specifically target your therapy towards whatever endocrine problem is mediating the disease. That's very different than idiopathic hypertension, where we kind of have drugs that we know work, but we don't know exactly why they work for different populations. So the vast majority of endocrine hypertension is mediated by aldosteronism, okay? And hyperaldosteronism will typically present as hypertension with hypokalemia. That's usually the trigger when hypertension comes along with hypokalemia that someone would start to try and figure out whether or not someone has an endocrine-mediated cause. And the first step in that evaluation is actually to check aldosterone and renin levels, and I'll show you why that is. But hypertension and hypokalemia can present with primary aldosteronism, high levels of aldo and low renin, but also low levels of aldo and low levels of renin. And that's because something else is inducing the same phenotype, hypertension, hypokalemia, but it's doing it not via aldosterone. And so there's hyperdeoxycorticosteronism, which comes in two different forms of congenital adrenal hyperplasia, 11 beta and 17 alpha. And there's also tumors of the adrenal, these are very rare, that make deoxycorticosterone, which we'll call DOC or DOAC. Okay, DOAC is a potent mineralocorticoid. It's not something we typically see in regular physiology because it's bypassed in the making of aldosterone. Then there are these disorders that are, kind of termed apparent mineralocorticoid excess. They look just like hyperaldosteronism, but when you measure aldo levels, they're actually low, pretty much undetectable typically. And so those are called apparent mineralocorticoid excess, of which there's a genetic form and then there's acquired form. And I'll walk you through this. I don't want you to worry so much about this nomenclature. I want you to be able to say, okay, there's hypertension, hypokalemia, maybe not even hypokalemia. I'm worried about endocrine-related hypertension. I'm going to do my evaluation, and I should know and be able to interpret aldosterone and renin levels so I could figure out where in the differential diagnosis I need to make the next step. So, just a quick reminder, here's the zona glomerulosa, okay, which is this pathway here. There is no 17-hydroxylase in the glomerulosa. It does not make glucocorticoids, and it does not make androgens. It's primarily responsible for mineralocorticoid. Aldosterone synthase is actually a series of steps, and those series of steps are under the regulation of angiotensin II. So here is deoxycorticosterone, or DOAC. This is that potent mineralocorticoid, but typically this is not a rate-limiting step. Actually, the rate-limiting steps are up here, and once this gets started under angiotensin II control, aldosterone is produced. And aldosterone is the main mediator of mineralocorticoid effects in the body. So what are the stimuli for aldosterone to be released? Well, there's two. There's this critically important one, which is a low circulating blood volume. Not a low circulating serum sodium level, because that's a measure of your free water compared to your solute concentration, but an actual low circulating blood volume. And the initial drop in a circulating blood volume is sensed by the kidney, which in the JGA cells are the primary mediators of this. Okay, they see less sodium coming through. That is not to say they see hyponatremia. So this drop in circulating blood volume, there's also a catecholamine response. So your sympathetic nervous system has a play in here as well. And the JGA cells secrete renin, which goes out into the peripheral circulation, takes angiotensinogen to angiotensin I, which is converted in a couple of different sites. The lung epithelium is a very important one by this ACE enzyme, angiotensin converting enzyme, from angiotensin 1 to angiotensin 2. Angiotensin 2 mediates its own effects. It's a vasoconstrictor. It's a stimulus for the sympathetic nervous system. So it has its own effects and its own receptors, but one of the things that angiotensin 2 does is go to the adrenal and upregulate the steps required for aldosterone synthesis. Aldosterone then has its effect. There's effects on the kidney cells to increase renal sodium reabsorption at the expense of potassium and hydrogen ions, and that restores circulating blood volume. Aldosterone also has effects that we consider to be non-classic. So there's effects that aldosterone has in the peripheral circulation. It sort of upregulates inflammation a little bit. Fibrosis, necrosis, those are not good things, especially when that hormone is in excess. And I'll get to that a little bit. The other main stimuli for aldosterone is actually hyperkalemia, which makes sense, right? There's too much serum potassium. You get an upregulation of aldosterone. It retains sodium at the expense of potassium, so you get potassium excretion. When there's sort of a bit of a check on the system, and that is that if the potassium level gets very low, it's actually a stimulus for renin and angiotensin release. But the low potassium itself blunts angiotensin 2's ability to make aldosterone. And that's a check so that you don't have life-threatening hypokalemia. It's a little bit tricky to understand, but just sort of pay attention to the way that this slide works. Yes, ACTH can be a stimulus for aldosterone secretion. It is not the stimulus for aldosterone secretion. That is angiotensin 2. Okay? So what does aldosterone do in the kidney? Well, it goes down to the collecting tubule, the principal cells in the collecting tubule. And through the next slide, I'll show you exactly how it does this. But it increases sodium reabsorption, increases potassium, and hydrogen ion excretion. The hydrogen ion excretion actually happens through the interstitial cells, not the principal cells. But you can see that here. So here is urinary excretion over a 24-hour period. They give an infusion of aldosterone. Potassium starts to rise in the urine, potassium wasting. Sodium drops in the urine, sodium retention. Protons begin to appear in the urine, so proton excretion. That's all physiologic. Okay, that's aldosterone's role. How exactly does it do that? So what you see here is the typical pathway for breaking down sodium channels that are on the principal cells in the collecting tubule. So ENaC is the epithelial sodium channel, and it allows for sodium transport or sodium reabsorption. And it, in the absence of aldosterone, gets broken down by this NED ubiquitin ligase protein. So the channels are on the surface, and there's a tight regulation. The channels are pulled off by this ligase and then broken down. What aldosterone does, as depicted here, is it crosses the cytoplasm, binds to the mineralocorticoid receptor, which is protected from excess cortisol by 11-beta-HSD2. That unit then acts as a transcription factor to upregulate serum glucocorticoid kinase 1. Don't worry about the name so much. But this kinase then phosphorylates the NED protein, which stops its ability to internalize the ENaC channel and break it down. So there are more sodium channels left on the surface. And that increase in sodium channels left on the surface allows for sodium reabsorption. Okay? And this was only recently, this was only sort of figured out about 10 or 15 years ago. Then the sodium-potassium transporters do their thing on the basolateral surface. So you can see here, it's not depicted, the mechanism is not actually depicted, but it's sodium reabsorption over to the basolateral circulation with potassium excretion I'm not depicting proton excretion because that happens in a different cell here. Okay, so this is the fundamental way that aldosterone works to restore circulating blood volume and to excrete potassium in the presence of an excess. So now we're going to get into some pathophysiology. So what is primary aldosteronism? Well, it's an inappropriately high aldosterone production, relatively autonomous, meaning it is leaving its negative feedback, and it is non-suppressible by sodium loading. And we'll talk a little bit about how important it is to ensure that it's non-suppressible by sodium loading. Okay? What are the effects? So what are the clinical sequelae? Well, high blood pressure mediated by sodium retention. There's an escape phenomenon, by the way, that happens after a couple of weeks of high levels of aldosteronism. So ANP levels rise, and there are other effects on the vasculature so that the hypertension kind of settles down a little bit. The salt retention settles down a little bit. You still do remain with very difficult to control hypertension, but it doesn't have as much salt retention and doesn't have as much edema. So that's called the mineralocorticoid escape phenomenon. The hypertension is often associated with hypokalemia, but this is really important. In more cases than not, potassium balance is normal. When you do see hypokalemia with hypertension, you should be very suspicious for an aldosterone-mediated process or some type of endocrine-mediated hypertension. But unfortunately, hypokalemia is present less frequently than we would expect it to be. Now, because of the proton excretion, there's also a metabolic alkalosis that occurs. This is kind of the opposite of the findings that we saw in primary adrenal insufficiency when there's an aldosterone deficit. And then, because of the sodium retention, there is a suppression of plasma renin activity. So this is the negative feedback right here. So let's look at a case. All right, 41-year-old male presents after discharge from his local hospital with hypokalemia. He was in his usual state of health. Nausea, lightheaded, palpitations, and muscle cramps all of a sudden developed. His potassium in the ER was 2.8. Vital signs showed hypertension. His prior history, he was told he had hypertension as a teenager, didn't follow up. Surgical history, none. Both parents have high blood pressure without cardiovascular disease, uses tobacco, no alcohol or drugs, no medicines, and no drug allergy. So who wants to just kind of shout out the, if you don't look at the next slide, 4 or 5 important points to this story that should make you say, well, this is not so typical for a blank-year-old patient. I just gave you the first one. His age, 41. Not so common to have severe hypertension at 41. Okay, what else? Yeah, the severity of his high blood pressure. This is not, 145/92, borderline. This is pretty severe stuff. That's a diastolic blood pressure that's quite significant. So he's young, severe high blood pressure. What else? Hypokalemia, good. His potassium is 2.8. That's actually the cause of most of these symptoms, in particular the muscle cramps. Family history of high blood pressure, very good. You want to know when the parents were diagnosed, if they were diagnosed early or if they were diagnosed in their 60s or 70s. What else? He's not on any medications. That makes this hypokalemia spontaneous. It was not induced by taking a medication that could lower your potassium level. That's very worrisome. Any others? No, no others. Good. Yeah, so he was told that he had high blood pressure as a teenager, but that just has to do with age. So case detection. How common is primary aldosteronism? Well, depending on how you define it and the catchment area for the patient population, you could be very rare, maybe 0.5% of all of hypertensive patients, or it could be pretty common. It may be as much as 10 or 15%. When this disease was first diagnosed, it was felt to probably explain about 10 to 15% of all high blood pressure, but it turns out it's probably somewhere in the middle. When should you be suspicious for this? You should be suspicious with all of the things we mentioned: high blood pressure and a young age, an incidental adrenal mass, what you will learn as resistant hypertension, which is high blood pressure that requires more than 3 drugs to keep it under good control, severe hypertension, okay, is a tip-off. Hypokalemia, as I said, is not, unfortunately, as common as we would expect it to be. It's very rare to be spontaneous, but one of the first drugs that's given for high blood pressure, all comers, is a very effective medication called hydrochlorothiazide or chlorthalidone. Those are both thiazide diuretics. Both of those cause potassium wasting, and in the background of someone with hyperaldosteronism, that can provoke hypokalemia. So be very wary of that, and a family history of endocrine hypertension. So how are you going to, so that we have our clinical history, we have our presentation, we have our reason to be suspicious. How are you going to test for this? Well, it turns out that you really need to do a morning upright normocalemic blood test. Well, why does somebody have to be sitting upright for you to do that test? If you're going to measure aldosterone concentration and plasma renin activity, which is the two main ones that we measure, you can directly measure renin concentration, but it turns out it's probably more useful to measure the plasma renin activity, and that's what I'm not going to talk about direct renin measurements any more than just to say that. Why does someone have to be seated? Go ahead. I heard something. Yeah. What about blood pressure? Right. When someone stands up, sympathetic nervous system goes up, renin levels rise, aldosterone levels rise. So when you're worried about this disease, someone kind of has to come into the office and sit for a little bit, maybe an hour or so. Okay? Why do they have to be normocalemic? Right, because hypokalemia suppresses aldosterone release, right? So you want to make sure you normalize potassium levels, or else you may get a falsely low aldosterone concentration. So that's very important. This is not something that just willy-nilly in the afternoon someone comes in, you see them, and you test them for it. If their potassium is low, forget what you just looked at. You have to replace potassium with supplements and then have them come back. It should be done in the morning. There's a little bit of a diurnal variation, and it should be done seated so you don't get the effect of postural changes. Okay, so how do we interpret the aldo and renin levels? Well, for the artists in the room, like myself, yeah?
Can it be that the hypokalemia is what actually induces the low levels? So by replacing the K, then you're going to be missing that?
Well, that's what I'm saying. So hypokalemia suppresses aldosterone release even in the setting of primary aldosteronism. And because we use an actual flat level of aldosterone concentration to decide who may or may not have this, you want to replete it so that you take that artifact away. The triangle represents what gland? Adrenal. Very good. And this thing represents the kidney. Good. Now, for some reason, they decided to help you remember this by flipping what was controlling what. But technically speaking, this picture is the only one here that is correct, because the adrenal glands sit above the kidneys and not below them, so don't get confused. But elevated aldo and low renin, and they're trying to depict that here by saying the aldosterone concentrations are suppressing the renin, is the disease we're about to talk about. Okay? But you may also get elevated aldos and high renins, and that is something that's pretty common. Remember, if renal perfusion pressure drops, renin levels go up, and that will drive up aldosterone concentrations. And so if you see high renin, high aldo, well, that's completely appropriate. That's actually the system that we expect to be in play. And that's called renal vascular hypertension, which you learned about in the renal course. Diuretic use can also do that. It decreases circulating blood volume, and you get a response by a rise in renin and rise in aldosterone concentration. So high aldo, high renin is secondary aldosteronism, not what we're looking at for, which is primary aldosteronism. And then what we'll talk about later is low aldosterone, low renin. And what that means, these blue arrows are trying to depict that something else is inducing the picture of hypertension and hypokalemia, that is not being mediated by aldosterone. So aldosterone levels fall. And I'll explain why renin levels are low as well. Okay? So this is a really important slide. Okay, so let's say we have an elevated aldosterone, plasma aldosterone concentration, and low renin. What's the differential diagnosis? Well, the two main forms of primary aldosteronism are an APA, aldosterone-producing adenoma, a unilateral adenoma that is autonomously secreting aldosterone and suppressing renin. That's a little less common than the other disease, which is idiopathic hyperplasia, bilateral adrenal hyperplasia, multiple little areas of hyperplastic adrenal tissue that are secreting aldosterone inappropriately, inducing hypertension, and suppressing renin. Okay? There are very rare things like primary or unilateral adrenal hyperplasia. It's very rare. To have an adrenocortical carcinoma that secretes aldosterone is very rare, not unheard of. Aldosterone-producing ovarian tumors. These we'll come back to at the end, particularly type 1. This is a fascinating form of hyperaldosteronism that's imminently treatable, extraordinarily rare, but very treatable. And it's called glucocorticoid remediable because glucocorticoids actually will suppress the hyperaldosteronism. So you say, well, why would that happen, right? Because aldo is under control of angiotensin II. Well, I'll show you why that happens in that particular disease. But it falls under this category of an elevated aldosterone concentration and low renin. So we have high levels of aldo and low renin. However, that doesn't make the diagnosis. All right? The aldo to renin ratio is merely something that allows us to increase our index of suspicion that someone may have primary aldosteronism. There's a lot of medicines, especially high blood pressure medications, that affect that ratio. And because it is a ratio, it's denominator dependent. The lower the plasma renin activity, the higher the ratio actually gets. And so it's not a foolproof test. It's pretty sensitive. It's not very specific. So a lot of times in the office, we have to pull people off of their blood pressure medications, wait for that all to wash out, and then retest somebody, which can be a little dangerous because they come in to see you for high blood pressure in the first place. It's not the easiest workup to do. So we do need a way to confirm that we have true hyperaldosteronism. And why is it so important to confirm it? Well, what happens is a lot of people see a high aldo, low renin, and they get a CAT scan. And they see a lump in the adrenal. And they send someone to surgery, and that lump gets removed. And they're still hypertensive, and they're still hypokalemic. Probably because there's a high rate of incidental non-functional adenomas in the general population that increases with age. And so incidentalomas of the adrenal are not uncommon. And because we see them not infrequently, we need to make sure that that adenoma or incidental finding in the adrenal is actually functionally producing that excess of aldosterone. The two most common forms of primary aldosteronism have completely different treatment paradigms. And so you really need to do a good job of not only clinching this diagnosis, but then trying to differentiate which one you're dealing with. Okay? And just so you know, this is somewhat controversial, but if you take people who have essential hypertension and people with primary aldosteronism, there is some belief that there's higher rates of chronic kidney disease and cardiovascular disease in the patients with primary aldosteronism because of those non-sodium effects of aldosterone, the increasing inflammation, fibrosis, and necrosis. It's a little bit controversial, though. So we are going to use physiology to assess for whether or not this patient truly has primary aldosteronism. Well, how did we define it? We said inappropriately high levels, somewhat suppressible, meaning not so suppressible. So what test can we do to try and prove that the aldo is autonomously secreted and not under physiologic control? Well, what's the normal physiologic release for aldosterone? Angiotensin II, which comes from renin, and the normal main way to stimulate renin release? Decrease circulating blood volume. So the opposite, if if you increase circulating blood volume, if you increase sodium load and suppress renin, do you still see elevated levels of aldosterone? In other words, if we absolutely remove renin and angiotensin II from the picture, are we still inappropriately seeing high levels of aldosterone? And that's called saline confirmatory testing. And you could do it in the office with an IV, or you could just have someone go home and tell them to eat 3 bags of Doritos 3 days in a row and come in for a 24-hour urine collection of aldosterone. When you do that, remember, though, you're driving up sodium-potassium exchange in the kidneys, so you have to be careful with each of these tests and make sure you're not inducing hypokalemia. So we do either one of these tests. You don't need to do both of them, but you do need to confirm that the aldosterone levels that you see are not mediated by renin. Okay? So these are saline suppression tests. The infusion test we don't really recommend doing because it's sort of known to exacerbate hypertension in the office. But it's a lot easier to do. And in order to make sure your patient took the sodium level you recommended, you're going to check the sodium in the 24-hour urine concentration. Don't get into the specifics of this. Just understand that an aldo-renin ratio itself is not diagnostic of this condition. We still need to do that classic, we have a hormone in excess, can we suppress it model of endocrine-based disease that I talked to you about before. So let's say we do that. We do the confirmation testing, and the disease is confirmed. So now we have 2 forms of this disease, an aldosterone-producing adenoma or idiopathic hyperaldosteronism. APAs are treated surgically. Unilateral removal of one adrenal gland. Remember, you need 90% destruction of both adrenal glands to have adrenal insufficiency, so taking out one of them is not going to induce adrenal insufficiency. So you can live perfectly fine with one adrenal gland. Bilateral adrenal hyperplasia, on the other hand, they used to operate and do a bilateral adrenalectomy. It didn't cure the hypertension for reasons that are not clear. So we treat this medically. And bilateral adrenal hyperplasia, which is more common, does not get surgery. So we really do need to figure out which one of these diseases that we're dealing with. This is what an aldosterone-producing adenoma. It's very nice and smooth and yellowish because of all the steroid production and all the cholesterol. This is bilateral adrenal hyperplasia. You can see all these foci of hyperplastic spots in the adrenal gland. Remember, APA surgically cures the disease. Hypertension, though, doesn't always go away because a lot of people have hypertension. And they may have just some essential hypertension underlying their aldosterone-mediated hypertension. In bilateral adrenal hyperplasia, we give medical treatment. And there's no role for surgery. So if we go back to our case, we say, boy, we should be really suspicious here. Okay? So we have an aldosterone level that's more than 15 in a morning, seated, normal kalemic, ambulatory patient, and a completely suppressed renin level. Okay, the aldo-renin ratio is really high. Usually it's greater than 30, but don't worry about numbers. So what do we do next? A renal ultrasound for renovascular hypertension? All hands? Good. An adrenal CT? Well, we know we're dealing with the adrenal glands. Let's take a look at them. Excellent. How about a salt load to confirm whether or not we have hyperaldosteronism? Good. Good. I'm almost breaking down your shyness, but not quite. This is what you need to do now. You need to do a salt load confirmation test. So we tell the patient, all right, we're going to give you sodium tablets. You're going to take 3 of these with every meal. We're going to give you potassium supplementation, and on the 3rd day, you're going to do a 24-hour collection of your urine, and it comes back that the aldo concentration is 25, and it should be less than 10 or 12. So we have confirmed it. Now that we've confirmed it, adrenal CAT scan is the next test. You can do MRI or CAT scan. They're both just about the same. Now here, you have a normal-looking adrenal. Okay, got that triangle shape. Here's 2 limbs. But over here where the adrenal is supposed to be, you have this adenomatous collection. Don't worry about that circle in there. Okay, you could just disregard it. So here we have a right-sided adrenal lump. So we have this 41-year-old. We've confirmed hyperaldosteronism. We do a CAT scan, and we have a unilateral adrenal mass. So who's taking him to the operating room? Take out the adrenal mass. Hands up so I can see him. Good. Who is giving them an aldosterone antagonist, like spironolactone or eplerenone? Because if it's aldosterone mediated, let's just give them a medication that'll block that. Nobody. And who's doing something called adrenal vein sampling, which you don't even know about yet? Yes, a brave person in the back is going to do adrenal vein sampling. Good. Actually, I just had a patient undergo adrenal vein sampling yesterday. Remember, okay, adrenal incidentalomas are not uncommon. And it turns out, and this is relatively new information, that CAT scans and imaging tests alone are not so reliable in telling us the mediator of the hyperaldosteronism. So in this study, 115 people got CAT scans. About 60 of them had a one-sided abnormality. 10% of those, when they had adrenal vein sampling, and I'll tell you what that is in a minute, had actual bilateral disease. No role for surgery there. Okay, so 10% we saved a procedure. Most of them there was agreement, though. For those patients who had bilateral findings, the majority of them actually localized unilaterally. Meaning, even though they saw bilateral adrenal hyperplasia, the culprit adenoma was sitting on one side. And so they would not have been operated on and may not have had as ideal an outcome as those who should have been operated on. So CAT scans compared to adrenal vein sampling are not so reliable. And no abnormalities, and this, I saw a case like this, unilaterally lateralized in about 60% of the cases. So even if you see nothing, you still strongly need to consider adrenal vein sampling, and I'll tell you what that is in 1 minute, as a means by which to figure out whether or not you're dealing with bilateral adrenal hyperplasia or an aldosterone-producing adenoma. Yeah?
When you say bilateral abnormality, is that the same thing as the focal hyperplasia?
It could look just like that. You know, lots of people have some nonspecific thickening or lumpy, bumpy adrenals. They may not say that there's a 2-centimeter adrenal mass on one side. They may say things like, we see thickened adrenals on both sides. And so you can't assume that that means bilateral adrenal hyperplasia. So this is adrenal vein sampling. Yeah? Is there really a purpose then for doing the CAT scan? Yeah, so it turns out that actually if you take a young enough group of patients, 40-year-olds and less, their likelihood of having an aldosterone, their likelihood of having an incidental adenoma of the adrenal is pretty low. And so in the endocrine world, there are some people who say if they're young enough, just take the thing out. And there's other people who say, no, everybody should get adrenal vein sampling. I think the world is moving away from operating on anybody without adrenal vein sampling. Everyone's going to need a CAT scan anyway. It's going to be part of your evaluation and your workup. So they go into the femoral vein, and they catheterize the left. I mean, this is probably a little bit of an over-representation, but they catheterize the left adrenal vein and the right adrenal vein. The right one's pretty hard to find, okay, because it goes right and it drains directly into the IVC, whereas the left one comes through the renal vein. The left is easy. The right side is hard. It makes it a little complicated. We really need to know, the endocrinologist really needs to know, and the surgeon needs to know, that that right adrenal vein was catheterized. And the way to know that is they're going to measure cortisol concentrations on the right, the left, and in the peripheral circulation. And they're going to give a big dose of ACTH and watch to make sure that those cortisol concentrations actually bump up appropriately. Because we expect a flooding after ACTH of cortisol to basically come out of the adrenal veins on both sides, and a much lower level in the peripheral circulation. And that's the critical way to know that they're in the right and the left. If they're not, and you can't confirm it, the test is unusable. Okay, this is done by interventional radiology with fluoroscopic dye. So we get some 5-minute values, some time zero values. They give an ACTH infusion, and then we get some 15-minute values. You could focus your energy here. Here's the peripheral levels of cortisol. They do go up, but look at what happens to the right and the left cortisol numbers. They markedly elevate, okay? And we have ratios to make sure that we're in the correct vein, so this is a good test. We know that the right and the left adrenal vein have been sampled. We then look at the aldosterone levels and correct them for cortisol for reasons I'm not going to get into, to make an aldosterone-cortisol ratio. So we have a right aldo-cortisol ratio here and a left aldo-cortisol ratio here. And then, they do this for a few thousand people, and it turns out that APAs have a 4-to-1 lateralization ratio. So the culprit lesion, which was on the right side of this very real patient who I presented to you, and the right side on the CAT scan, has a right-sided aldosterone-producing adenoma. And we can go in and safely operate on this patient. If this ratio was less than 3-to-1, that's concerning for bilateral adrenal hyperplasia, and that person does not go to the operating room. So this is adrenal vein sampling. This is the kind of data that we actually get and need to interpret. You'll notice that there's a rise in aldo levels, okay, on the left and the right side, which is one of the reasons why we need to correct for cortisol. So, critical to distinguish between these two diagnoses, APAs get a unilateral adrenalectomy, 100% cure of the hypokalemia. That is not a problem anymore. You don't cure everyone's hypertension, and there's reasons to expect in older patients that they're going to have some underlying essential hypertension. But it won't be that aldosterone-mediated hypertension anymore. And so it may have less CVD and CKD risk. IHA, on the other hand, is not cured even with bilateral adrenalectomy, so we use medical therapy. We use aldosterone receptor antagonists. The more common one is spironolactone. The other one is called the Plerinone. They actually bind to and antagonize the mineralocorticoid receptor, so they do not allow aldosterone to do its work. Unfortunately, spironolactone is not specific, so it's actually an androgen receptor antagonist, so in men it causes hypogonadal symptoms. And also, it's a progesterone receptor agonist, and that can cause problems for women with interrupted menstrual cycles. A Plerinone does not have those two nonspecific effects. So it doesn't promote progesterone activity, and it doesn't have anti-androgen activity. It's a lot more expensive, but they both pretty much work equally effectively, although I'm not aware of head-to-head RCTs on them. Yeah?
Can you use case-sparing diuretics?
These are considered case-sparing diuretics. Like triamterene or amiloride? No, they're not going to be effective for this. Because you're not specifically lowering the aldosterone, so you may have an effect on sodium reabsorption, but as I said, there are sort of non-classical effects of aldosterone that we get concerned about. Now, there are patients who are not going to go for surgery. They're too old. We think surgery would be risky. It's perfectly appropriate to give them aldosterone antagonists. So that's the main forms of primary aldosteronism. But there are these two familial forms, which is why you ask about family history. Focus your energy on type 1. It's an autosomal dominant form. It occurs very early in life, so childhood onset of hypertension with hypokalemia. It's refractory to medication. It's the typical blood pressure medications we use will not assist with this. But it is responsive to glucocorticoids. And fortunately now there's genetic tests. So if you have someone you're working up with primary aldosteronism, you always want to take a good family history and find out how early their high blood pressure developed and keep this disease in the back of your mind. What is happening in this is that this is the normal situation. The aldosterone synthase promoter, which is in front of aldosterone synthase and mediated by angiotensin II, right? That's the production of aldosterone that we typically expect. Right next door, we have the 11-hydroxylase promoter, which activates 11-hydroxylase and produces cortisol. That's in the fasciculata. That's under ACTH control. These patients with this form of glucocorticoid remediable hypertension and primary aldosteronism actually have a fusion of the 11-hydroxylase promoter in front of aldosterone synthase. And so their zona glomerulosa becomes exquisitely ACTH responsive. And they begin to produce aldosterone in excess. And angiotensin II is not playing a role here anymore. And this is very refractory to most forms of therapy. However, if we had a means by which we could lower ACTH levels, we might be able to treat them effectively. And that's one of the ways to make this diagnosis. You know, you give a few medications, blood pressure is not getting any better. You do a dexamethasone suppression test, blood pressure is completely okay within a couple of days. Nowadays, we use genetic testing to actually make this diagnosis. But this is sort of a fascinating disease. It's very rare, but sort of classic endocrine physiology will allow you to figure it out. Okay. Now, as I said, there are causes of hypertension that may or may not present with hypokalemia that look just like primary aldosteronism, but when you measure your morning, seated, normal kalemic aldo levels, you find low aldo levels and low renin. And so what's happening there? Well, it's a mineralocorticoid-like picture that's not being mediated by aldosterone. And so there's a couple of different forms of that disease: hyperdeoxycorticosteronism, and there are also apparent mineralocorticoid excess syndromes. And so let me show you a little bit about what those look like. I'm not going to show you a picture of this. A DOAC-producing tumor is exquisitely rare, usually pretty bad if you find it. They're usually quite large. And what will happen is someone will present all of a sudden with hypertension, hypokalemia, your aldorenin levels are completely undetectable. You'll start going down your workup, and DOC levels are going to be very, very high. Those patients get imaged. You'll usually find a large adrenal mass that needs to be resected because of the risk of carcinoma. So just be aware that DOAC-producing tumors exist, but they're extraordinarily rare. Now, I did mention the other day that there's a couple other forms of congenital adrenal hyperplasia I wanted you to be comfortable with and responsible for, and they are here. It's the same fundamental concept, okay? Autosomal recessive genetic disease, diverse phenotype, male or female. There's classic forms of these and late onset forms of these. The common theme remains that there's an enzymatic defect in the normal production of cortisol, which allows for an increase in ACTH that induces hyperplasia, okay, and a shunt towards either precursors or the one or two products that can actually be generated. So it's the same pathway here. Let's focus on 11-beta hydroxylase first. This is the second most common form of congenital adrenal hyperplasia after 21-hydroxylase. And I depicted it in red. So here's the block, 11-beta hydroxylase. And the buildup is 11-deoxycortisol in the fasciculata and DOAC in the glomerulosa. There's also a shunt to androgens. So in young females, there will be virilization. Now, DOAC is a potent mineralocorticoid, and it will bind the mineralocorticoid receptor when it is in excess concentrations. We don't typically see much of it in the peripheral circulation. When it is in excess concentrations, it'll bind to the mineralocorticoid receptor, induce sodium retention at the expense of potassium and hydrogen ions. And because it induces sodium retention, there's a negative feedback that suppresses renin. Okay, aldosterone can't be made. It's further down the chain. The block is here. Okay, so aldosterone does not get made. This is another mineralocorticoid that is acting like aldosterone and suppressing renin. Okay, so it's early onset again, depending on the severity of the enzyme block. Hypertension, hypokalemia, virilization for a young female, and adrenal insufficiency if it's very, very severe. Okay, so that's 11-beta hydroxylase deficiency. Another form is 17-alpha hydroxylase, and this one is quite rare. 17-alpha hydroxylase is needed to make glucocorticoids and androgens. Now we're talking about no androgens being made. And that could cause feminization of a developing male, because this actually happens in the testes and the gonads too. But in the adrenal, it's still the same premise. So there's no ability to go down the glucocorticoid pathway, or a limited ability depending on the enzyme defect, or the androgen pathway, and things get shunted to the mineralocorticoids. However, it doesn't go, you don't get high concentrations of aldosterone. Can anybody figure out why that would be? Anybody? Yeah. Right. No, the feedback mechanism is actually working just fine. What happens is that there's so much shunting down this pathway that you get elevated levels of DOAC and other precursors. You get high levels of those mineralocorticoids that are not aldosterone, which suppress renin, which suppresses angiotensin II, which suppresses the production of aldosterone. So low aldo levels, low renin. Okay? Always got to think about negative feedback. What's supposed to be generating this enzyme? Okay, so those are the two forms of congenital adrenal hyperplasia that can present looking like hyperaldosteronism. Here we come back to our favorite enzyme, 11-beta hydroxysteroid dehydrogenase type 2. There is an error, by the way, in your syllabus. It's been pointed out to me by a couple of people. There's a line in there about the potency. There's a potency table for glucocorticoid and mineralocorticoid activity, and it says cortisone with mineralocorticoid activity. The syllabus is not the most up-to-date, but what I believe that they are mentioning is cortisone as the pharmacologic agent that we give, which is hydrocortisone. Endogenous cortisone, which is what is made by 11-beta hydroxysteroid dehydrogenase type 2 from cortisol, has zero mineralocorticoid receptor agonism capability. Okay? And that brings us to this disease, this apparent mineralocorticoid excess. 11-beta hydroxysteroid dehydrogenase type 2 either doesn't work when somebody is born, or there's an acquired decrease in the ability for that enzyme to take active cortisol, which will bind the mineralocorticoid receptor, to cortisone, which has no mineralocorticoid activity. So if the enzyme doesn't work, there's much higher circulating concentrations of cortisol than aldosterone, and cortisol binds the mineralocorticoid receptor. It's not aldo that's mediating that effect. And so it looks like a mineralocorticoid excess, but the aldo levels are low. Same negative feedback that drives down renin. Does anybody know the food that needs to be ingested in high quantities in order to turn that enzyme off? Licorice. Like the red Twizzler stuff that you see at the movie theater? No, that's called sugar. No, it's the actual licorice root, the compound that's in real licorice, that can do this. And there's also a medication that's not used in the United States. It's glyceric acid is the compound that turns this enzyme off. While I show you this, we talked about, and you saw it in the table in the small group session, ectopic ACTH production of cortisol typically has the highest levels of cortisol that there are. The levels of cortisol are higher in ectopic ACTH than they are in Cushing's disease, because in ectopic ACTH there is no feedback whatsoever. It is just autonomous secretion of ACTH. In pituitary adenomas, you have a right-shifted set point. So as glucocorticoids go up from the adrenals being stimulated by the adenoma, those glucocorticoids go back to the adenoma and kind of put it in check and suppress it a little bit. So there's a yin-yang there. There's no yin-yang in ectopic ACTH. And it's ectopic ACTH is the form of Cushing's that overwhelms 11-beta hydroxysteroid dehydrogenase type 2 and presents, not uncommonly, with hypertension and hypokalemia. And it looks like a mineralocorticoid excess. And then lastly, there is a disorder called Little syndrome. Now, Grant Little is one of the, great names in endocrinology. The dexamethasone suppression testing all came from Grant Little's lab. Dr. Fleischer, who did the hypothalamic pituitary talk, he worked in Grant Little's lab. Little described a syndrome that he didn't understand at the time. He didn't have the molecular understanding of why this syndrome was happening, but he was able to describe a family, autosomal dominant early onset hypertension, where spironolactone or aldosterone antagonism had no role. Okay, it's an aldosterone independent disease, but it looks just like aldosterone or mineralocorticoid is mediating it. And what actually happens is that there's a defect in the epithelial sodium channel such that it cannot be ligated and broken down by the NED enzyme. Remember, that's how aldosterone, or the lack of aldosterone, does its effect. So the ENaC channels don't get ligated, they hang around longer, and they're actually more active. And so somebody asked me about, well, can't you just treat the sodium channels in aldosterone-mediated disease? And I said, no, that wouldn't be as effective. In this disease, in Little syndrome, spironolactone and eplerenone would not work. All right, because it's aldosterone independent. What affects this disease and what helps in this disease is to get something to block the ENaC channels, and that is where something like a miloride or triamterene, an epithelial sodium channel blocker, would be effective. This is extraordinarily, extraordinarily rare, but it's the same physiology and pathophysiology, so I think it's important for you to understand that. And then I think, as promised, here's your recipe, should you want to make whole wheat pumpkin muffins. And that's it. So we have our small groups in about 10 minutes, and I'll hang around for some questions, and I look forward to seeing you there.